Dr. Voorhees, as you know, in 2013, what really brought me back into the emergency room was one morning. It was actually September 14th of 2013. I was 1 a.m. in the morning getting out of bed, and as I placed both of my feet onto the floor to stand up, my back collapsed. I fell back onto the bed, screaming in agonizing pain. My partner, Julian, he calls 911 services, and an ambulance comes and whisks me away. My back is really spasming uncontrollably, like I'm in severe pain. And the nurse is asking me questions, and I still feel like I wasn't getting no blood work, no labs, and I think they were just more focused on the pain. And they gave me some pain meds and said, okay, you can get up and you can walk out now, you've been discharged. And I was like, discharged? I'm having back spasms, I can't physically walk. And so my partner, who is a physician, he asked to speak to the ER doctor in charge, and he said, can you do a simple CT scan on him? He may be discharged, but he's not going anywhere. And so once they did a CT scan, they came back immediately. And that's when the doctor said, we're admitting you to the hospital. You have lytic lesions throughout your entire body. And that's pretty much how they left it. But the look on Julian's face, I knew something was wrong. And I immediately asked him, do I have cancer? And he did not respond. And he was like, they need to work you up first. And so as I'm getting worked up and then I get the CT scan, he was like, you have a fracture of your L1 and your L3. And I was in disbelief. And then as I go upstairs and I'm admitted, a few hours later, now I'm in complete renal failure. I have a hemoglobin of 6.8, so I'm anemic. And it just kept going on and on and on. Now I have a fracture of my L4. I have another additional fracture. It was a lot from a patient standpoint. And I still get choked up about it, even thinking of it, because I'm one of those patients who was misdiagnosed.
Yeah. No, this is not an unusual situation for patients, unfortunately. As you know, multiple myeloma, can, destroy bone. And, spontaneous bone fractures are a consequence of that. So patients coming in with the sudden onset of back pain for no good reason. And for you, who was at the time, otherwise young, healthy, physically active, this back pain story just doesn't quite fit, right? So you guys did the exact right thing to push for additional testing because you shouldn't be having that pain. So you did the exact right thing. But unfortunately, this is how many patients with newly diagnosed myeloma present and are diagnosed. These spontaneous compression fractures in the spine leading to incapacitating back pain, fractures in other parts of the skeleton, for example, kidney failure as a result of high antibody production by the myeloma cells, anemia because the bone marrow is just overrun with disease. So what we really want to do is to be able to identify this earlier in the game, diagnose people when they're not suffering from all of these setbacks related to their multiple myeloma, so we can onboard them onto therapy appropriately before catastrophe strikes. One of the things that we noticed just at our own institution, we did a retrospective look at, how patients presented with multiple myeloma in our own institution, and we looked at what that looked like, for folks who are Black, where multiple myeloma is twice as common, and other races. And surprisingly, perhaps 25% of our newly diagnosed Black patients with multiple myeloma were hospitalized with complications of their disease at initial diagnosis, whereas it was a 10% likelihood of hospitalization at initial diagnosis for those of other races. And that kind of suggests, that, our Black patients were being diagnosed with multiple myeloma later in the game, where more of these, catastrophes are starting to strike and landing patients in the hospital. We want to get away from that. We want to diagnose patients early and start them on therapy before those sorts of complications start to arise.
Right, which is what happened to me. Having to go through radiation just to control the back pain, they weren't even focusing on the cancer diagnosis once they told me on September 18th of 2013 that you're diagnosed with high-risk multiple myeloma. And I'm like, what is multiple myeloma? And I later learned that it's a rare form of leukemia. And it was very daunting, like, not knowing what you're dealing with, but I'm a very positive person. I'm a strong individual, so I never thought about like this was going to be the end of my life. I knew that I had to fight, but those rounds of radiation, as well as doctor visits in and out of the hospital, being in the hospital for 3 weeks, and then you're being whisked off for an additional 2 weeks at a rehab facility to learn how to regain your strength and walk again because of the back fractures.
Yeah, and this is exactly why we want to be able to diagnose people earlier in the game, because not only were you suffering from all of the complications of your disease, but now we have to apply all of this therapy, which has its own set of side effects associated with it, the radiation therapy, and then the myeloma-related chemotherapy. So you're really dealing with two, different pieces, which really make it hard to recover in that early period. The fortunate news is that myeloma therapy has become so effective that we're generally able to get control of the disease very fast, so we can start mitigating some of those myeloma-related complications pretty quickly. That said, when you've sustained a compression fracture of your back, even once you've treated the myeloma into remission, you still have compression fractures, you still have back pain, all the more reason to diagnose the disease earlier.
Yes, so me recounting back to Carvykti in 2019, I was at a conference. I remember it so well in Orlando at Tandem, and I took a screenshot, a photo, and I sent it to Dr. Voorhees via text right away and said, is this something that I should consider, we should talk about? And he responded back, we can definitely discuss, but not for you at this moment. So we started to have those conversations after that, because I think at that point I was in only 3 lines of treatment coming from, starting at that point in 2019. But that conversation continued like throughout the years. Once my numbers started to creep up a little bit, I always said, like, I've never had a drug holiday. I've never not been on treatment. It's been almost 12 years and I've always been on chemotherapy, and I'm like, I just want a break. I just want a break. So 2024 comes into play. We're talking about, well, I haven't had any of the CD38 drugs. So there was a lot of different things that we could do, but I always said right away, I just want a break. I don't want to go into infusion center anymore. And he said, Carvykti will give you that. So that was the decision.
Yeah, and the discussion, has evolved over time, because when we first started talking about Carvykti, it was FDA approved for patients with very advanced disease who had relapsed at least 4 times and had been exposed to kind of all the core pillars of myeloma therapies available. And that's the way it typically works in oncology. You apply a new therapy to patients who are starting to run out of options, and if it's effective and it's safe, it gets approved for use in patients, and then we start to bring it earlier and earlier into the course of the disease, treatment continuum, especially those promising therapies like Carvykti. So, flash forward to 2024 when we're having this conversation, and your myeloma is starting to tap at the door as the M spike is, slowly rising. We have the CARTITUDE-4 study, which was a phase 3 study that compared Carvykti to standard of care regimens for folks relapsing for their first, their second, and their third time. So these are less heavily pretreated patients than the original study and the original approval. And that study showed that Carvykti was more likely to lead to a response. It was more likely to produce a long response, and it was actually associated with better overall survival as well. So the FDA made a decision to approve CARVYKTI for folks relapsing for the very first time. So there's a much greater swath of patients who can take advantage of this CAR T-cell therapy now relative to the early days when we first started talking about it, when it was still in clinical trials.
Right.
It's true that you got a lot of mileage out of our proteasome inhibitors and our immunomodulatory drugs for many years, but we were actually able to leverage the fact that you'd not been exposed to CD38 antibodies to use those as part of your treatment plan to kind of get you to CARVYKTI therapy. And that's one of the nice things about using CARVYKTI for folks, that are relapsing for their first, second, or third time. There's more myeloma drugs available to us to be able to get your disease under good control in the lead up to CARVYKTI, CAR T-cell therapy. That's treatment before we collect the T cells from you to engineer the CAR T cells, and also during the manufacturing process, we can apply much more effective therapy when we use these earlier. Because I've told you over and over again, as we were kind of getting ready for this, if we go into CARVYKTI infusion with a low burden of disease, we should really be able to mitigate some of these side effects that you hear about related to CAR T-cell therapy.
Yes. And after talking about it and going through it in May of this year, in 2025, and saw you on Monday of this week, and you share with me that I was MRD negative and pretty much cancer-free, so.
Yeah.
And I still can't wrap my head around that moment. I'm still digesting that still to this day.
Yeah, no, we couldn't be happier with the results, but the bone marrow was absolutely clear.